Good afternoon, and welcome to Reducing Physician Burnout Update, a webinar tweet chat from Health Systems CIO, sponsored by Nuance. Just a little housekeeping before we get started. My name is Anthony Guerra, and I'm the Editor-in-Chief of Health Systems CIO, and I will be your moderator today. We are having a simultaneous tweet chat hosted by Kate Gamble, our Managing Editor and Director of Social Media. You can participate in a separate browser or on your phone by using the hashtag HSCIOchat, or you can simply view the tweet chat in the Media Viewer panel on the right-hand side of your screen. We have a few features we're going to bring to you today. One is a polling segment, which we call Agree or Over the Top. That'll automatically open when we launch it later in the program, so we encourage you to chime in on that poll. And we also encourage you to use the Q&A box to submit any questions as they occur to you, and we'll take those later in the program. Leave the default on that set to all panelists. And you could download the deck by using the URL on your screen. It's also at the bottom of your slides. Just so you see how we're going to spend our time today, first we're going to go about 35 minutes or so with our featured panel discussion. Today we have Maia Hightower, Dr. Maia Hightower, CMIO at the University of Utah Health, Dr. Stan Huff, CMIO at Intermountain Healthcare, and Dr. Bret Shillingstad, CMIO with Nuance. So without further delay, we are going to jump right in. We've got a lot of good stuff to talk about today. Maia, let's start with you. Can you give us an overview of your organization and role?
Sure. So my organization, I'm at the University of Utah Health. We are a leading institution, academic organization when it comes to the quality of care that we provide for our community, as well as for our national partners, as well as the world, as a leading academic medical center. As far as my role, so I'm the CMIO, and I've been with the University of Utah for about 6 months now, started in March. Before that, I was the CMIO at the University of Iowa. And here, my role is very similar to in Iowa, where definitely a lot of leadership around the EMR, the EHR, and provider informatics. So I do lead a provider informatics team. As well as 3 other teams that are a little unique to our org structure here at the University of Utah. So I have the Enterprise Data Warehouse team, as well as a Data Science Services team that provides data services to our research community. And then the last team is a Knowledge Management and Mobility Solutions, where we use our team there develop Smart on Fire apps to really improve the usability of the EMR. That is our focus, and have a campaign called Reimagine EHR. So really being able to make the EHR usable for our providers using the latest advances in standards around interoperability.
Excellent. Thank you, Maia. Stan?
So, as you said, I'm the CMIO of Intermountain Healthcare. Intermountain Healthcare is centered in or headquartered in Salt Lake City. We have 22 hospitals. We have about 35,000 employees, and we provide a substantial share of the healthcare in Utah. My role is not that different from Maia's. I'm very focused on standards and interoperability. Others are more directly focused on sort of frontline activities, but I spend a lot of my time working with HL7 and actually creating standards. Been involved pretty heavily in fire and smart on fire kind of activities, and also in LOINC terminology and SNOMED terminology and those other standards, actually OMG standards also for creating interoperability. And we just, our focus in that interoperability is, in fact, so that we can share knowledge, so that we can start sharing. And we actually have done some, we're working on joint projects with the University of Utah in sharing smart applications between the two institutions. And so that's been a lot of fun.
Excellent. Thank you, Stan. Bret?
Yes, Bret Shillingstad. My background is in general surgery, which I practiced for several years. And after doing mostly every other night call, since my wife's a surgeon, I transitioned to Epic, where I spent 12 and a half years as the director of clinical informatics. And after being at Epic, really wanted to get into third-party solutions that connect into the EMRs to reduce physician burden. So that's been a combination of optimization, especially for specialties, connecting third-party solutions such as voice, ambient clinical solutions, as well as artificial intelligence. So it's been fun to now connect other things to kind of take the EMRs to the next level.
Excellent. Very good. All right, Stan, let's start with you on this. I guess we go for sort of a baseline, getting a definition here. How would you define physician burnout, and what are some of the causes that do not relate to the use of technology?
Well, I think physician burnout, I'm not sure of a proper definition, but the way I think about it is that physicians are burdened in a way that they're no longer enjoying practicing healthcare because they're doing all kinds of other bureaucratic things rather than what they went into medicine for, which is interacting with patients and trying to help people get better faster. And so, yeah, there are all the technology issues. The other things, though, are just, I think it's, as physicians, that, used to be a really small sort of industry, and people were in their own offices and had a lot of autonomy. And as things have changed and reimbursement have changed, then they're in larger groups. They're subject to, corporate policies, and above all, and I think that, a lot of the trouble is actually caused not so much by technology, but by bad policy from the government. And, I think the most of the meaningful use things have contributed heavily to that because they always have unforeseen consequences. And I think we have to fundamentally change the incentives so that the incentive is to provide high-quality care at a low cost, and get away from all of the measures and all of the meaningful use things and those things which inevitably cause physician work, and also it leads to managing measures instead of managing healthcare. And so that's an introductory thought about that.
Very good. Thank you, Stan. Bret?
Yeah, and I think physicians are just under a lot of pressure where they're having to see more patients, generate more procedures to generate the same revenue since reimbursement's falling. And then you throw, a tool, which is the EMR, into the mix, which doesn't mimic workflows, and it really impedes efficiency. So you really have to find ways to adapt workflows to support efficiency. A lot of the problems, too, is EMRs came out as primary care tools initially, not really focused on specialties. And it's just imperative that you have different tools for a high-volume specialty flow. And then really where I think we've gotten to now is, now that we have some specialty tools, is you really have to personalize at the physician level. And a lot of that is making physicians take the time to see how they can personalize workflows and what they do to kind of get to that next level. So there's a lot of challenges, and I totally agree with compliance. Compliance has been one of the biggest roadblocks, which I don't think had been intentions, but has led to a lot of unforeseen consequences.
Very good. Maia?
Yeah, so I think as far as, defining physician burnout, there are definitions around like Maslow's burnout scale and difference between emotional exhaustion and to depersonalization. But when it comes down to what physicians are feeling, it's really that dread of coming to work caused by the stressors of their work environment, and that as Stan mentioned, to just that lack of joy of practicing medicine that brought physicians to the healthcare field in the first place. And then as far as the causes, it's multifactorial, and it's definitely not just technology. As alluded to by the two prior speakers, the regulatory environment, which is a combination of like meaningful use and how do we implement this digital tool that had poor adoption when we compare healthcare industry to other industries. We just weren't progressing, and so hence we are where we are when it comes to that regulatory desire to incentivize adoption of electronic medical records. But that environment is not in a void either when you look at the shift from fee-for-service to value, the rising cost of healthcare, and the associated regulatory environment around that shift to value. And then our expectations of patients are different. It's not what the compact that many of our physicians entered when they started medical school. The patient community has a different expectation of what it means to interact with the healthcare system. The real focus on patient experience, where one would hope that there really is this perfect alignment where patient experience and physician experience really are partners and are intertwined, but sometimes that pressure, that change can feel like they're two separate things, and patient experience is really driving, or patient-centered care is driving a dissatisfaction for providers. As well as just our digital environment in general. I mean, I think when you think about our lives outside of healthcare, they're pretty stressful too, and they too are filled with digital changes that weren't there before, including social media and the pressure to keep up with Joneses and all sorts of other external stressors that our kids are facing. When we were talking about being parents, and being a parent in a digital world is, I would imagine, a little bit more stressful than it was 20 years ago. I don't know, but for any parent that's had that fight over the cell phone, the iPhone or something like that, then we're all facing different challenges than outside of our work environment and inside of our work environment that we haven't been able to necessarily cope well with.
I think that's a great point, Maya, that there could be an overall increase in stress, maybe for professionals, maybe for everyone, that's underlying some of this stuff. And that doesn't mean we shouldn't try and fix some of this EMR stuff we're going to talk about, but that's a very interesting point, that life in general could be more stressful. So very interesting. Okay, next question. Bret, let's start with you. So I don't know if we put a number on it, but to what degree is the EMR contributing to physician burnout, and in what way is it contributing?
Yeah, I think it probably is, a substantial contributor, maybe, 50% or so. The areas where I think it's made it tough is a lot of the workflows were fairly efficient on paper, but you see going to an electronic system that a lot of tasks get pushed off on the physician. For example, I would never see normal labs or results as a physician on paper. My nurse would get it off my desk and contact the patient, and it was done. But a lot of that has been moved to the physician, where they're seeing all the alerts and all the data, much of which they never would have touched before. And then you have people not really working at the top of their licenses, so you have physicians taking on tasks, even helping with coding and other billing issues that they didn't do as much of. And it leads to a lot of noise. So not only do I see patients, but I have this in-basket that I have to deal with all this other stuff, which definitely increases that load. And then, I think when you get trained on an EMR, you maybe retain 20% of what you need to know at go live and forget 80% of it. And basically you're in this survival mode. So you can survive and get through a day very inefficiently. And it's really hard, unless you do some personalization and one-on-one, to get them from just being a rudimentary user that's just barely making it through the day and then doing a lot at night to being efficient and thriving with a new tool. And I think, that's really where we've gotten to.
Yeah, we've all had that experience, right, where we've been doing something a certain way, in our computer or some task, and then someone goes, "Oh, what are you doing? You don't have to do that. Well, you just click here." And you're like, "Oh."
Right.
So, they've been struggling through the best way they can, but yeah, that other 80% that they didn't retain can be very valuable, to your point. Maia, thoughts?
Yeah, so I think that the EMR, it's really easy to think that to put the burden of physician burnout on the EMR, and it definitely contributes to it in that efficiency of work component of physician wellness, and that's the Stanford model of physician of wellness has the efficiency of work, culture of medicine, and then personal attributes, sort of all contributing to wellness. And I think, though, that the EMR really has been used as a tool for change. We're in an era where change is rapid, and that tool can be perceived either as a useful tool for change or a weapon of change. And so many of the changes that have been mandated, regulated, and encouraged have been implemented within the EMR without much creativity on how we could do it differently. And so I think that the EMR is being used as a tool for change, to drive change, and because of that, it's seen as contributing. It is contributing greatly to physician burnout, but it doesn't have to be that way.
Very good, Stan.
Yeah, as mentioned, I think there are two big things. One again is policy, and I'll just use an example. I mean, I was on the HIT standards committee that approved and at least aided and abetted a lot of the meaningful use rules, and we thought we were doing a good thing, and saying things like, physician needs to, actually do the medication ordering. So if there's an alert or something, you can take immediate action. And sure, everybody ought to be notified about smoking cessation programs, et cetera. But then I'm getting older, so I'm consuming as much health care as I'm providing. And I go in, for my own appointments, and I go to my gastroenterologist for my, 10-year, colonoscopy screening, and he says, "Stan, what have you done to me? I see you once every 10 years, in good circumstances, and you really think I'm supposed to talk to you about smoking cessation? I mean, that's not the right way to do it. And now you've got rules where, used to be my nurses and my staff could order, bowel preps, which is what I do most of the time, and now I have to do that. And so that's what I mean by unexpected consequences. People don't think about, they think about sort of the happy path sort of implementation of these things, not realizing the impact it has in specialty clinics and, people who are not my primary care doc, but are still held to the same requirements if they want to get reimbursement. And so there's that combination thing. I think that's actually the biggest, if I had to say, and other requirements of documentation to bill that the government puts on us. And then the other part really is, though, just poor system design, so that it's not, the programs aren't conformant to the workflows. They're not easy to use. So there's a lot that can be improved there. But if I had to say, I think the biggest thing is the requirements for billing and regulation and other things that really aren't the. We can't blame the EHRs for those things. That they came from Washington. So.
Very good. Very good. All right, next question. What can be done to reduce the frustration some physicians are experiencing when interacting with the EMR? Maia?
I think this is definitely a multifactorial sort of approach, people, process, technology. So one is just making sure that from a technology perspective that our providers have the most efficient tools available to them to be able to document and to do their work. Part of it is partnering with companies like Nuance for voice recognition, voice to text, and even that pathway into the future which hopefully will be sooner than we think, to a complete hands-free encounter environment where there's a virtual digital assistant that really is doing a lot of the work behind the scenes. So technology-wise, I think being on that pathway to a seamless digital experience is extremely important. I also think in the meantime, because that isn't going to develop tomorrow or be developed tomorrow, even if we have that pathway, in the meantime, really it is making sure that we have the support, peer support. I mean, there's a huge difference when you have an IT person or our wonderful trainers helping our physicians, and they do as best they can, but a peer that is embedded within the workplace, that is that sort of confidant, goes a long way. So that one-on-one with a trusted peer, a physician informaticist, I think it really makes a huge difference. And having a personalized approach where that provider can spend that one-on-one time with a peer, addressing areas where they can really make a difference, intervenable changes with using some of the personalization tools within the electronic medical record. And then from a workflow perspective, really ensuring that when we are designing workflows and the EMR is laying on top of those workflows, that we really create top of the licensure use a delegation of tasks. And so if that is an MA task, it should remain an MA task, and what has been shifted to the physician burden should shift back to the MA and nursing staff burden. That working to the top of the licensure is so extremely important, and that's where we need to have that creativity in thinking about, okay, it's not just, and the regulations are actually quite clear that the doctor doesn't necessarily have to check that box. It often will say, or their delegate, and making sure we have the processes that allow for that conferring to the delegate of that bowel prep or that pending of medication, or even per protocol signing the medications. And so really using our care teams to the fullest extent.
Very good, Maia. Thank you. Stan?
Yeah. I think, coming back to the interoperability, one of the things that I think is necessary, and this also we talked about in terms of specialization and the need for workflows to be specific to specialties and that sort of stuff. And one of the ideas behind that is the smart on fire and creating an environment where third parties can create software that integrates with the EHR, and it's independent of any particular EHR as long as the EHRs adhere to the standards. And so the whole, smart on fire kind of strategy, and the idea being that then you can have some groups working, specialty groups can come together and they can make extremely convenient and user-friendly applications that really can't be created by the vendors in the same way. And those then, if people are adhering to the standards, somebody that makes a really good program now, that's something that could be used everywhere, in the world. And that it reduces so much, because we're in the situation now, if somebody makes a good thing, at the most, it might be used by one vendor. And then it has to be reprogrammed in a different system if you want to move it on. And it's probably the least efficient way to create software if you have either one organization or just one company that you're working with, and you can't scale because people can't share. And so I think one of the keys is, in fact, that creating that infrastructure of interoperability so that we develop a marketplace that looks like the kind of marketplace you see when you go to the App Store, or the Android, or wherever you go to get your the things for your phone, for your smartphone. there's an incredible opportunity there, and I think we need to invest in creating the infrastructure so that those kinds of really elegant applications can be created, maintained, and the whole population, everybody can take advantage of those in how they take care of the patients. And it's especially important, not just thinking about the workflow and that part, but the ability to implement clinical decision support on a national level so that everybody has the same benefit of sepsis screening in the ER or programs that help manage community-acquired pneumonia, neonatal bilirubin, et cetera, et cetera. I mean, I don't think I can overemphasize the value and power of being able to share applications and especially being able to share knowledge as executable programs that will not only make physicians and patients' lives better, but they will have better, higher quality care at a lower cost.
Excellent. Thank you, Stan. Bret?
Yeah, and I would reiterate a lot of those things. I think, if you look at tip sheets, physicians just aren't going to read a tip sheet or read email tips. They might rarely look at a video. It's tough to get physicians to go to classes, but I think with Maia's comment of using physician champions or trainers or physician assistants to do one-on-one is just hugely valuable. To get a physician to give up 2 hours and tell them, we're going to try to save you 2 hours every night from this point on by doing some personalization and optimization. Instead of just, speaking words into a note, let's use templates. Let me show you how you can navigate using your voice throughout the EMR. Let me show you how to set up your top 20 procedures for your common order sets with all your preferences. When you get down to that level and doing some one-on-one, the payoff can be huge. And I think that that's something where organizations need to realize once you go live, you're not done. You still need a lot of trainers and physician champions and experts to go back out and really get people to the next level. Plus, there's always upgrades where you need to do the same. And I completely agree with Stan that, the more we can standardize connections in and out of the EMRs using FHIR and third-party apps, even just with content, the EMR vendors are not typically content experts, and to find easy ways to get content and tools in and out of the EMRs is something that I think is so beneficial to physicians.
Very good. Thank you, Bret. Okay, next question. Let's start with Stan on this. Can or should Scribes play a role in easing physician frustration with the EMR?
I would say yes. I would qualify that, though, by saying, I hope that's short term, because I hope the kind of things that Nuance is doing and that Maia mentioned, overcome that need. I think the advanced technology is there to do all kinds, to do computer vision coupled with, voice recognition and other things that we can make an incredible environment. But, those things we haven't, though they're technically possible, I don't think we've made them sort of day to day yet. And so, I think while we kind of mature that opportunity, that office of the future kind of vision, I think it would be appropriate to try and reduce burden using Scribes.
Bret?
Yeah, and I think Scribes have really seen some short-term benefits. I think they have to be deployed in a very thoughtful fashion where you're not just trying to cover up problems. You're actually trying to figure out how it's going to help the physician see more patients and generate revenue. There's a great story at Rush that I know Dr. Patty has talked about where they used Scribes successfully in the emergency department where they were using voice recognition, but then went in and did one-on-one training and did some optimization. And at the end of that, they voted 70-1 to get rid of their scribes and save themselves over $800,000 a year. And I guess if you thoughtfully can use scribes, that's great. But I hate to have them just cover up problems where you could just fix some underlying workflow solutions.
Maya?
Yeah, I would agree with Bret in that regard. My favorite scribe model is the MA scribe, where the medical assistant is a day in, day out part of the team and really helping the physician as part of a team. And they're doing more than just documenting information, but teeing up the visit and being that flow manager and really providing a crucial skill set to the team, documentation being one of them. And I think that's my favorite scribe model. I think the other scribe models kind of, whether they're virtual scribes or in-person scribes, kind of have their limitations, pros and cons. I mean, you get your documentation done, but you're not getting CPOE, you're not getting in-basket management or really top of the licensure care team approach. And so, as Bret mentioned, kind of looking at workflow is really important, and then the type of scribe model that an institution is interested in considering. And again, my favorite is the MA scribe.
Yeah, and just adding on to what Maya said with the MAs, I think that's a great point. It reminds me of Mercy in St. Louis. They actually put a complexity score on their schedule for every patient and had the MAs go in and see the sickest patients before the doctor, and the doctor would just go see the very quick and easy patients because it didn't make sense to have an MA and a doctor go in for a quick visit and do the same thing for 5 minutes. But with the sickest patients, the MA would go in, hear the stories about the grandkids and the pets, go through that giant bag of meds and get everything into the EMR. And then when the physician came in, it was very fast, efficient. A lot of the stuff had been sorted out in the chart, and they could very effectively take care of the patient by using the MA, which was lower cost to do a lot of that pre-intake. And their patient satisfaction scores went up. The doctors were seeing more patients an hour. But I think if you can find unique ways to use the MAs, maybe in a counterintuitive fashion, you can get some big wins there.
The grandkids and pets, that's not top of the license stuff, Bret?
Well, it's fun to hear about it, but, after 20 minutes, you're going, oh, man, I've got 3 more patients to see.
Right. Very good, very good. All right, next question. I want to start with Stan on this. What specifically are you doing in your health system to reduce physician burnout? Have you seen progress, and what are some tips on measuring progress for our listeners?
So, what we're working on is really resources to further optimize and configure our EHR system, and to create better workflows and to train people. It really is sort of around system optimization to improve that, and it's working. It's slow. It's not, it's not timed by a stopwatch, but by a calendar, in terms of progress on those things. And it's hard work, but we're working on that. The other thing that we're doing is in fact investing in this idea of smart on fire applications and starting to share applications that we can get from outside and third parties, and things that we create that we're able to share back in the same way. So it's small, but we've done some things that we've done some smart on fire things, and things that have actually things that we've shared with or borrowed from the University of Utah in terms of a really nice pediatric growth chart, and then some, things around neonatal bilirubin management and some other things. And those things, are making an impact. I don't know how to measure. I mean, we do some satisfaction studies and things, but there's probably a better way. I have to say, I don't think I'm an expert on how to measure whether we're making progress or not.
Very good. Maia?
Yeah, so we're taking a three-pronged approach to creating this exceptional EHR experience. The approach, one is implementing best practices around the EHR experience for our providers, and we are starting a Home for Dinner program. And it's really being marketed as a home for whatever it is that the provider wants to do, but anything but the EHR. And so it really is a peer-led provider informaticist one-on-one elbow support program, dedicated time to improving the personalization of the EHR for that provider. So spending a lot of time doing that. It is also, we're having a care team approach where nursing informatics is working concurrently with the nurse support team, the MA or nurse that's supporting that provider, and ensuring that they're using Epic as well to the top of their licensure, and maintaining best practices around in-basket management, teeing up the note as well as the orders, that kind of thing. And then a workflow component that has a value engineer looking at workflow. Especially many of our clinics have been working on workflow optimization and ensuring that any slippage that has occurred, we sort of redirect and ensure that they're continuing to maintain those efficient workflow practices. The second prong of our exceptional EHR strategy is growing our provider informatics team. So again, that peer-to-peer, one-on-one social network around the electronic medical record, building trust as well as communications with our providers, I think is extremely important. And then the third component of that exceptional EHR experience is using Smart on Fire apps. Our team, a knowledge management and mobility solutions team that is essentially reimagining the EHR, building out the bilirubin app that Stan had mentioned, as well as now moving towards chronic disease management, really providing that application overlay on top of the EHR that is so much more usable, as well as decreases the amount of clicks, makes it an efficient experience for our providers and care teams. So that's what we're doing.
Excellent. Thank you. Okay, next question. Let's start with you, Bret. Is there a common misconception or an incorrect path you think people could be tempted to go down as they try and tackle this problem that we can help them avoid?
Yeah, and I think, a lot of times in EHR design, project teams will say, well, that's the way the doctors asked for it, and that's what we gave them, and they need to learn to use it. But I think a lot of times until you use it, you don't know how it really should have been set up. And I think having the capability of being willing to change and reconfigure workflows and build is something that organizations have to be open to. And if it's build that's low effort with huge return, that should be stuff that everyone should be looking for. I think the other thing that has had relatively low adoption that ends up being a big win is mobile solutions. And I think now that mobile solutions are much more robust to place orders, to use macros and do a lot of stuff they couldn't do, getting back out there and having physicians revisit stuff that wasn't robust enough 3 or 4 years ago, that's actually a huge win now. And then, I think the other thing is if you give orthopedic tools to orthopedists, for example, that's not enough because the ankle and foot guy has a totally different practice than the shoulder guy who has a completely different practice than, say, the joint replacement guy. And within every specialty, everyone has a totally different top 20 conditions they see, different education materials they use, and you have to be willing to get down to that subspecialty level where every doc has the top 90% of orders and templates at his fingertips to get through the day.
Very good. Stan?
I would just emphasize that, we've never done anything right the first time. So I guess don't give up. I mean, it it truly is that, it came to mind from what the things Bret was saying. But, Al Pryor, who is one of my mentors, he used to always say, clinicians know what they want when they see it. But if you just build what they tell you and think that's going to be sufficient, then that's going to be a mistake. Because, again, as he said, you'll learn more in the first hour of live production use than you will in a year of sort of engineering and, interviews and that sort of stuff. Because people just, it's almost impossible to understand how software fits into the workflow, especially if you have to consider response times and who's doing what and what's the proximity of the other person that's doing something just before I do what I do, all of that sort of stuff. We've never gotten it right the first time, and yet, the second or third time, you get things right. And, you can see that, for instance, just in the utilization. We have a program that Scott Evans created a long time ago that prompted clinicians, help them choose the most cost-effective antibiotic for a given infection based on suspected site of infection, age and sex of the patient, community acquired, et cetera, that kind of stuff. And the first time we put it out, we just got an avalanche of why does it do this, why does it do that, and then we fix things and we fix things.
Yeah. Yep.
And within a few months, the recommendations were being received and acted on 90% plus of the time, as prompted by the computer. And so, I would say the error is just giving up too quick, or take time to optimize, and don't expect that just talking and doing interviews is going to get you the information that you need to make a really good application. It just takes some time, and it takes some experience in the actual clinical environment to tune those things to be the best that they can be.
I think that's an excellent point, Stan. And Maia, I'd like to get your thoughts. And interesting, just if you want to also comment on what Stan was saying a bit, it seems to me that from the process he's describing, you would want to encourage your users to have a little patience and to say, we do want feedback and we know this isn't perfect. Can that be part of the formal process of rolling things out?
Oh, yeah, absolutely. I think that's where the provider informaticists have those boots on the ground are so important, because they are the ones that are hearing the concerns of their providers, their peers, as well as have that direct feedback loop to the greater IT organization. And so they're often our pilot group, the ones that will first kick around the tires and have iterative changes based on sort of this engaged provider champion group. And then they're also then accountable and for keeping those communications open once it's been released into the greater community to bring back that feedback so that we can continue to tweak and iterate. But as far as the question around common incorrect path ITs folks sometimes take, I think that we need to make a distinction between personalization, optimization, and customization. Personalization and optimization are awesome. Those are really, especially when we're talking about a big system like Epic, or I imagine for Cerner as well, but definitely for Epic, you really want to be the voice of personalization and optimization, being able to configure things and learn from those configurations. Historically, we did a lot of custom code. Any old Epic organization that's been around for some time, there was a need for development of solutions that addressed local problems, because initially the real impetus were more on national, like meaningful use and other kind of functionality. So we built all sorts of custom code, which now it can be really challenging to maintain an environment that has a lot of custom solutions. And the vendors have been so efficient at responding to the marketplace that often what was once this great custom solution is overshadowed by what is available from the vendor directly, and that pathway of retiring a custom solution to adopting the commercially available solution, I think is an important one to tread. And nowadays, I think we've all been burned by the custom approach. That in general, I don't think I've met a CIO or a CMIO yet that's like, we love custom code.
Yeah. And there's a big industry now around transitioning applications and moving the data and sunsetting old ones. That's a big issue now as well. So, very good. Okay, we're going to go with a little feature now we have called Agree or Over the Top to get our audience involved. So I'm going to open that poll now. So you got your two choices for each of these statements, agree or over the top. So go ahead and start answering those, and I'm going to have our panel discuss it as well. So first statement, and I am going to go with Stan on this. EMRs are not user-friendly because they were created to facilitate billing.
So I would have to agree. It's not all or nothing, so that's maybe why it makes it a controversial question. But there's no question that a lot of the functionality in our EHR systems are meant for cost capture and for billing purposes, and that it's not and it's not just the government, but it's also our insurance sort of infrastructure. And so if you look at how things are documented in the U.S., there's a lot of documentation that goes on because it's needed to justify billing. And if you look at the same sort of clinic visit in a European country or in a country that has a single insurance plan, the note contains what's needed to take care of the patient, not what's needed to bill accurately for the encounter. And so I have to say it's obviously not exclusive. I mean, the EHRs do a lot more than bill, but there's certainly our systems are burdened tremendously by the need to bill.
Very good. All right, Bret, you are going to address the next one. EMRs turn physicians into data entry clerks. Agree or over the top?
I would say I agree with that. The problem is I think EMRs were used as a tool for compliance people to get back at the doctors. And, doctors should have been doing this, or I always wanted the physicians to do that. So I think, a lot of tasks got moved to the physicians out of compliance and design. And it's unfortunate because if you even think of before surgeries or procedures, the MA would fill out the orders and the doc would just walk by and sign it, and the staff would schedule procedures. And, all that stuff gets moved to the physicians. And coming up with workflows where staff can pen orders and all the physician has to do is some quick cosigns is the way stuff should work. But I think compliance has been a challenge. And one of the main things I've done, I think, in the past 12 or 13 years is just connecting organizations with another organization that allowed other staff to do tasks for the doctors. There is no uniformity for compliance across this country. Every place does it different, and every place generally passes Joint Commission visits. So there is a lot of flexibility, and I think the revenge of compliance has kind of contributed to the data entry clerk complaint.
Very good. All right, Maia, for the last one. The degree to which physicians like their EMR is directly related to the purchase and rollout methodology used by the IT department rather than the vendor product being used. Do you agree, or is that over the top?
Yeah, I would agree with that. I think that, the EMR relationship really begins with the dating process, like any relationship, right? And so the amount that the providers and the users, the community has been involved with the purchasing, the transparency of that process, extremely important in creating that connection with the EMR. And then the rollout methodology when it comes to the training And again, that relationship and trust is being built. And I think the Arch Collaborative does have some studies on the quality of the training as perceived by the end user. If they perceive that they had high quality training, it's correlated with a better EMR experience. So I agree.
All right, very good. We're going to share our results now. So for the EMRs are not user-friendly because they were created to facilitate billing. We have that split. 44% agree, 44% over the top. For EMRs turns physicians into data entry clerks, 31% agree and 56% think that's over the top. And the degree to which physicians like their EMR is directly related to purchase and rollout methodology rather than the vendor, 75% agree and 19% think that's over the top. So that is how our audience is weighing in on that. All right, we have a few audience questions that I want to get to. Let's start with the first one. How much of alleviating EMR frustration comes from changes in technology versus, quote, the human factor, that is training and peer support, etc.? Maia?
Yeah, I think it's a bit of both. So training is extremely important. And again, that class Arch Collaborative research has shown the importance of training when it comes to at least anything EHR related. And then the technology itself, as the technology changes, especially when usability is a key component of that change, as we improve usability, intuitiveness, design, that too is a huge factor, I think, in provider efficiency in the EHR.
Very good. All right, next question. Class mentions EHR use contributes to 20% of the R squared of provider burden. Is that number surprising to the panelists? Stan?
Well, probably surprising the other way. I thought it might be even more. Yeah.
A little bit more. Go ahead. Any more on that?
Nope, that's all I got.
Bret?
Yeah, and I think it matters which half of the EMR they're thinking about. If it's data retrieval, everyone loves the fact that there's not one paper chart they have to go find. So consuming data, the EMR is pretty good, but it's some of the entry and workflows that are tough. So I guess it depends on which half they're looking at when they're answering that question.
So I think the clarification is, it's surprising that it's so low at 20%.
Yeah, I would have expected a bit more myself.
Okay. Very good. All right. I want to get one Ask a Co-panelist in here, and then we're going to run. I'm going to give it to you, Bret. Do you have a question for either or both of your co-panelists? And then we're going to get shaking.
Yeah, I would be interested just from hearing from Stan how he feels FHIR adoption is going with the major vendors. I've always seen a lot of willingness to allow third parties to consume data, but not as much to write back to the EMRs. And do you think there's progress being made and enough adoption with the EMRs?
Well, I'm encouraged by at least their public support for it, but I would hasten to add that at least our experience has been, and I'm familiar with some other areas besides Intermountain, the progress is much slower than we would hope. I think in a lot of ways, there's a difference in mindset. When I think about Smart on FHIR, I think of actually sort of transition. I'm thinking of a transition to the EHRs as being platforms where the applications and the workflows are provided through Smart on FHIR applications that are coming from third-party vendors. And I think what I've seen is that people, the vendors, the EHR groups are committed to doing FHIR, but write back is hard. That's certainly lagging behind the ability to retrieve data. And then the overall robustness of that, the performance, other things, there's a lot more standardization that needs to go on, and that'll be harder, and it'll take more time. But they're committed. I think the thing, I just think about these companies that, depending on who we're talking about, we got companies with 10,000, employees and 15,000 employees and like that. And, the last I knew, most of those companies weren't investing more than 10, 20, 25 people in developing the fire things. And so it's a tiny percentage of their whole sort of development effort that's being focused that way currently. So wish there was more faster.
All right, very good, Stan. Thank you so much. And thank you. That's about all we had time for today regarding continuing education. Those of you who hold the CHIME CHCIO certification get 1 CEU for attending our events. If you've asked us to let CHIME know you were here, we will. Otherwise, make sure you let them know. You'll receive an email when the on-demand recording of this event has been posted to our site. If you'd like to sponsor one of our upcoming events, you can check out our sponsorship webinar calendar, or you can contact Nancy Wilcox and go to our website to register for upcoming webinars. With that, I want to thank Dr. Maia Hightower, Dr. Stan Huff, and Dr. Bret Shillingstad, and I want to thank Nuance very much for supporting this event and facilitating this great conversation. And I want to thank you, our attendees, for coming to our events. So with that, everybody have a wonderful day. Thank you.